Recently, the all-inside technique for anterior cruciate ligament reconstruction has gained remarkable popularity. The rapid dissemination of this method has largely been driven by global manufacturers of surgical implants. My colleagues often ask me why I do not use all-inside reconstruction technique. This question became the starting point for this presentation. My presentation is not an attempt to convince anyone of anything. It reflects my personal perspective on the problem. If it encourages you to look more broadly at modern surgical techniques, more critically, I'll consider the goal of this presentation achieved. The term all-inside is somewhat misleading when compared to the meniscal repair technique bearing the same name. In meniscal surgery, all-inside correctly describes a technique that allows meniscus suturing using special devices without additional incisions. In ACL reconstruction, however, the term is far less accurate. In fact, the term inside-out would be more appropriate. According to the literature, Craig Morgan and Leo Pinchevsky aimed to improve techniques to facilitate revision surgery, while Chadwick Prodromos and James Andrews sought to reduce surgical invasiveness, mainly through the development of retrograde drilling technology. However, all these methods required complete removal of the ACL remnants. The key question is preserving 1 cubic centimeter of cancellous bone worth any sacrifice? And can such surgery truly be called minimally invasive? I'll not compare cortical fixation with interference screw fixation. Despite providing rigid fixation, interference screws and the associated tunnel widening became a major problem in revision ACL surgery. Therefore, we will compare the traditional ACL reconstruction technique using a complete tibial tunnel with antegrade drilling to the all-inside technique. Most scientific publications on the all-inside technique reach nearly identical conclusions, which can be summarized as follows. The all-inside technique has the advantages of using a single tendon graft, less early postoperative pain, and similar clinical and functional outcomes compared to the complete tibial tunnel technique. Let us attempt an unbiased comparison of these two methods. On the left side of the slide are the widely advertised advantages of the all-inside technique. On the right side are the corresponding responses of the complete tibial tunnel technique. One of the main claimed advantages of the all-inside technique is good visualization of the internal aperture during femoral tunnel formation. In the traditional technique, this issue is effectively solved by using a 70-degree scope, which allows visualization of the femoral tunnel through the anterolateral portal. Personally, I always use a 70-degree scope in ACL reconstruction. Another claimed advantage: no need for significant knee flexion during femoral tunnel formation. However, if the knee flexes beyond 110 degrees, this advantage becomes irrelevant. How often do we perform ACL reconstruction in patients whose knees cannot flex beyond 90 degrees? In extreme cases, flexible reamers can be used for femoral tunnel drilling. Next advantage: minimal invasiveness, greater bone volume preservation during tibial tunnel formation. At first glance, this seems clear, but there is an important nuance. We performed CT scans in patients operated on using our complete tibial tunnel technique. The scans showed that within 3 to 6 months, the distal part of the tibial tunnel, not occupied by sutures or graft tissue, was spontaneously filled with cancellous bone. At this time point, CT images were similar to those seen after the all-inside technique. This occurs without the use of retrograde reamers. This video shows a revision surgery in a patient with post-traumatic ACL graft rupture. CT imaging demonstrates that the distal part of the tibial tunnel is filled with bone. we can see the external aperture of the tibial tunnel after removal of the cortical fixation device. The branches of the instrument can barely be introduced. The tunnel remains open only where the sutures pass through. Another claimed advantage, possibility of using a semitendinosus graft alone, preserving the gracilis tendon. This is an important option. However, nothing prevents us from preparing a short graft without using retrograde trimmers and fixing it with cortical buttons. On the right side of the slide, our graft preparation technique using corrugated sutures is shown, with the final appearance of the prepared graft below. Another advantage, high cosmesis. On the right side, postoperative wounds after traditional ACL reconstruction are shown. If the length of the tibial incision is only twice the length of an arthroscopic portal, this can reasonably be considered cosmetically acceptable. Now let us discuss the disadvantages of the all-inside technique, probably the more interesting part, since they are rarely addressed. The first and main disadvantage, the ACL stump must be completely removed. To retrogradely pass the graft using the all-inside technique, complete removal of the ACL remnant is required. After such preparation, the intra-articular view of the knee resembles a scorched earth field. Other clear disadvantages include high cost of surgical supplies, inability to use hybrid graft fixation techniques, requirement for an additional femoral incision, and enlargement of the anteromedial portal to insert the graft, raising questions about cosmesis. Preservation of distal tibial bone is meaningless for revision surgery. This scorched earth approach in the modern all-inside technique looks particularly strange in light of numerous publications emphasizing the importance of preserving the ACL stump. Thus, with the all-inside technique, we completely remove the ACL remnant to allow retrograde drilling and intra-articular graft passage in order to preserve 1 cubic centimeter of tibial bone, which can spontaneously regenerate within months after surgery. This formula sounds irrational, yet an increasing number of surgeons continue to use it. Our approach to ACL reconstruction is as follows. Tendon graft preparation using corrugated sutures, which provide additional press-fit fixation of the graft within the bone tunnels. After graft insertion, tightening the corrugated sutures increases the graft diameter within the tunnels. Another crucial component, creating tunnels in the correct anatomical areas of the femur and tibia while preserving the ACL stump. Isometric graft positioning is one of the most important aspects of ACL reconstruction. To ensure this, we developed and patented a technique for verifying tunnel isometry before drilling. Next key element, graft fixation with reliable and user-friendly cortical fixators. We have developed and patented cortical fixation devices for ACL reconstruction, and a seed is used for femoral fixation, and the cap is used for tibial fixation. Due to its special geometry, the seed allows easy passage through the narrow part of the femoral tunnel and provides clear tactile feedback during cortical flip. Thanks to its spikes and protective flange, the cap provides rigid fixation on bone at the external aperture of tibial tunnels, with diameters ranging from 8.5 mm to 13 mm, making this fixator universally applicable for both primary and revision ACL reconstruction. This is how the proposed fixators appear on radiographic images. In our view, this represents anatomical and biologically correct ACL reconstruction. Arthroscopic view. The femoral and tibial tunnel areas are identified. Visualization throughout the procedure is achieved using a 70-degree arthroscope through the anterolateral portal. The femoral tunnel is drilled over a guide pin. Then the tibial tunnel is created while preserving the ACL stump, first within a 4.5 mm drill, then enlarged to the graft diameter. The graft is passed through the tibial tunnel, through the preserved ACL stump, and into the femoral tunnel. As a result, a large portion of the graft within the joint cavity is surrounded by the ACL remnant, which promotes biological integration. During knee motion, the ACL stump does not interfere with graft function. In conclusion, I call on all of us to view any widely promoted surgical technique through the lens of critical thinking. Only in this way can we continue to progress and avoid moving in the wrong direction, even when that direction is recommended by many.